Okay, excuse me. We're almost done. So we've covered a lot of GI issues, and that, like we said, is caused from the progesterone, which is a relaxer of smooth muscle. Um, the other thing about the liver and GI is that gallbladder disorders are they have an increased incidence in pregnancy, and that's because of the hepatic function and bile transport. This also tells you that if you did LFTs on a mom, and the alkaline phosphatase is increased, that's normal. It's due to the placental production of that particular enzyme. So you're going to see that um, this result elevated, but that's physiologic. Because the placenta produces its own hormones, and protein binding is increased in pregnancy, the pregnancy affects most of our endocrine systems. So, like I said a few minutes ago, HCG is similar to TSH. And this is again discussing that TSH level. I don't know if I mentioned this, but if you have a low TSH, hyper, right? So if you have a low TSH indicating if you have a low TSH indicating a hyperthyroidism, that's true. So unlike an elevated TSH, which could be caused by this HCG similarity, if you have a low TSH indicating hyperthyroidism, that is true. Because if you think about it, it actually should be reversed, right? If it were a physiologic change, you would actually have an elevated TSH. So if it's actually low, then there's no way, like that just has to be the diagnosis. So you go ahead and manage that hyperthyroidism, which again, we'll discuss next semester. The placenta also releases CRH, corticotropin releasing hormone, which increases ACTH. And those are the things that aldosterone and cortisol contribute to edema as well. Stress of pregnancy, increased human placental lactogen and insulinase by the placenta. So those are what, think back to gestational diabetes. This is what causes our insulin resistance and the increased need for insulin. The melanocyte stimulating hormone, that's what we get those maternal skin changes. And the pituitary increases its function by about 135%, and the prolactin level is very high. And, that makes sense physiologically because the body is getting ready for lactation. All of those skin changes, again, are caused by the hormones and the MSH. The lipid metabolism is drastically changed, and that has to do with the insulin changes and the inhibition of lipolysis. So if you, if you draw a mom's blood, let's say she needs her wellness screening labs for her health insurance. I do get this a lot. When you check that cholesterol and triglyceride, those are going to be extremely elevated. So you have to just tell mom that, okay, this is not going to be an accurate test because you're pregnant, and explain to her that. Sometimes the insurance company doesn't care. They just need the number to put in a chart. Sometimes I will write, a professional note saying that these are going to be inaccurate because of the pregnancy, and that we would retest them like at our 6-week postpartum visit. So if you did do this and you see those numbers elevated, that's normal. This is covering how the placenta transfers nutrients and oxygen, but mostly nutrients. So you have several mechanisms. The 3 main ones are simple diffusion, facilitated diffusion, and active transport. This table in Hacker and More, you definitely should know that information. Simple diffusion, as you remember from chemistry, hopefully, that low molecular size and lipid solubility are what promote that. Facilitated diffusion is by glucose, and glucose is the main energy source of the fetus, and then active transport with amino acids. So be sure that you review that table. This is reviewing the placental transfer of oxygen and carbon dioxide. So the maternal lung actually consumes, like as in uses for itself, very little oxygen from maternal blood. The uteroplacental circulation is where fetal gas exchange happens, right? Because the fetal lungs are not functioning. So the placenta is basically the lung of the fetus at this point. Are you amazed at all the things that the placenta does, right? So you have a gas exchange, oxygen, carbon dioxide. They all cross the placenta by simple diffusion. So 20% of the uterine blood flow is shunted to the myoendometrium, right, which is where the placenta is attached. And then the fetus also supplies blood to the placenta and fetal membranes through the umbilical cord. So the vein of the fetus, like the pulmonary vein, is carrying the most highly oxygenated blood. So think of that as not peripheral veins, but the pulmonary vein, right? So it's the most highly oxygenated blood. Again, that is not involved in respiratory gas exchange. Babies are learning to breathe in utero. They are breathing in amniotic fluid, and amniotic fluid is actually what keeps the lung tissue and alveoli open, and that is how fetal lung development actually happens. So sometimes the further gestation, you'll see more active breathing, and that's actually one of the measurements of fetal well-being in some other things that we'll talk about. And that's because of sensitivity to oxygen deprivation. That's why fetal breathing is used clinically as an indicator of the adequacy. So the breathing is inhibited by hypoxia. So instead of trying to breathe more, right, the fetus conserves its energy in every way, shape, or form to maintain any oxygenation right to the brain. There is what we call a dissociation between the maternal oxygen carrying capacity and that of the fetus. So you can see there that is correlated to the saturation of the mom and the PO2, and this is called the Bohr effect. And that is because of the placenta, and that is how, because of that dissociation, that's what facilitates oxygen transfer from mom to baby. And this is basically all from Up to Date, ACOG, Your Hacker and More, and then there are a few things from Merck manual here, but pretty much all of this is from your textbook. So I apologize that we didn't get to this in class, and I apologize that the lecture is so long. But if you have any questions that you can't find in your text to answer, then just let me know. Thanks, guys.